Shall I start?
Sadi, sir?
Yeah. I'm here, Munipriya. I'm there.
Oh, okay, sir.
Shall I start, sir?
Yes, you can
Yes.
start now. Yeah.
Good evening, everyone. I would be discussing about the pharmacotherapy in benign prostatic obstruction. Regarding the primary choice of the management option of benign prostatic enlargement, the medical therapy has superseded the surgical treatment. So the agents available at the moment are alpha-1 adrenoreceptor antagonists, the 5-alpha reductase inhibitors, the muscarinic receptor antagonist, beta-3 agonist, and the phosphodiesterase 5 inhibitors, and phytotherapy, the plant extracts, and the combination of above medications. So I would be discussing about the alpha-1 adrenoreceptor antagonist first. This inhibits the effects of endogenously released noradrenaline on smooth muscle cells in the prostate, and thereby reduce the prostate tone and the bladder outlet obstruction. So the agents available are alphazosine, doxazosine, the tamsulosin, the terasosine, and new agents. This agents reduces the IPSS by approximately 30 to 40% and increase the Qmax by approximately 20 to 25%. So then the alpha-1 and blockers can reduce the both storage and void in low urinary tract symptoms. Regarding the adverse events of alpha-1 blockers are asthenia, dizziness, and the orthostatic hypotension. It also can cause intraoperative floppy iris syndrome in some patients, and it is selected as the first line drug therapy for the male low urinary tract symptoms. Regarding the commonly used agent, the tamsulosin, benzene sulfonamide type drug, and it's more effective in treatment of the benign prostatic hypertension and little effect on the then it's well absorbed the oral medication, and T-half is 5 to 10 hours. So it's extensively metabolizing cytochrome P50 liver metabolism, and it's contraindicated in the patients with sulfa allergy and patients taking cytochrome inhibitors. And its known side effects are the retrograde ejaculation, intraoperative floppy eye syndrome, as I mentioned earlier, and the usual dose is 0.4 milligram single dose, and can go up to 0.8 milligram daily dose. Regarding the EAU recommendation of alpha-1 blockers, these drugs are effective in reducing urinary symptoms, as I mentioned earlier, the IPSS, and increasing the peak urinary flow rate Qmax compared to placebo. And the strong recommendations of regarding the alpha-1 blockers are that they can offer patients who are having moderate to severe low urinary tract symptoms with strong evidence. Regarding the 5-alpha reductase inhibitors, these are predominant expression. There are two types of 5-alpha reductase inhibitors, type 1 and type 2. Type 2 variant is the predominantly expressed in the prostate. Usually the androgen effects on the prostate, and it's mediated by the dihydrotestosterone, DHT, which is converted from the testosterone by the enzyme 5-alpha reductase. So the agents available in this inhibitor agents available are dutasteride and the finasteride. The two drugs has different action. Dutasteride has both type 1 and type 2 inhibitors, and the finasteride only type 2 inhibitors. So this drugs promotes the apoptosis of the prostate epithelial cells and leading to reduce the prostate size. About 18 to 28% decrease in circulating size, and it decreases the PSA levels also about 50% after 6 to 12 months of treatment. So that's an important point with regarding the prosthetic management. So regarding the, as I mentioned earlier, these are the type 1 and type 2 5-alpha reductase types and their actions. Deuterocyte had both action, and the finasteride only act on type 1, type 2. That's more specific for the prostate gland. So regarding the 5-alpha reductase, the inhibitors, they improve the IPSS by approximately 50 to 30%. And it decreases the prostate volume by around 30% and increase the Qmax by 1.5 to 2 ml per second in patients with LUTs due to prostate enlargement. And it reduces the long-term risk of acute urinary retention and progression of the symptoms and going for the surgery. There are two studies, the PLES study, that's finasteride. There they have described the finasteride reduces the relative risk of acute urinary retention by 57% and the need for surgery by 55% at 4 years. And the MTOP study, there finasteride reduces the relative risk of acute urinary retention by 68% and need for surgery by 64%. Again, that's 4 years. It also has advantage of reduces the blood loss during the transurethral prosthetic surgeries, and the common side effects are the reduced libido, the erectile dysfunction, and less frequently it has some other ejaculatory disorders such as retrograde ejaculation, ejaculation failure, and decreased semen volume. And interestingly, British Taiwanese population-based cohort study, they have demonstrated the risk of type 2 diabetes was higher in men with 5-alpha reductase inhibitors. And it can be used in the patients with moderate to severe LUTs and enlarged prostate, usually more than 40 ml size prostates. So these are the summary of the evidence and recommendation of the EAU. I would go with the recommendation, the use of 5-alpha reductase inhibitors in men who have moderate to severe LUTs and increased risk of disease progression. Prostate volume more than, they have strong recommendation. And before that, they have suggested that the counsel the patient about the slow onset of actions with 5-ARS because of the slow action on prostate gland. Patient might not be very satisfied with the initial period. Then the beta-3 agonists, these are beta-3 adrenoreceptors, are the predominant beta receptors expressed in the smooth muscle cells of the detrusor muscles, and their stimulation is thought to induce the detrusor relaxation. So the agents available are the mirabegron. Then regarding the muscarinic receptor antagonist, the detrusor is innervated by the parasympathetic nerves, whose main neurotransmitter is acetylcholine, which stimulate the muscarinic receptors. There are M1 to M5 receptor types, and the most predominant types are the M2 and M3 are expressed in the detrusor muscle. So the agents available are darifenazine, festoradine, oxybutynin, then solifenazine, and the tolterodine are the agents available. Regarding the recommendations of EAU, the use of muscarinic receptor antagonists in men with moderate to severe LUTs who mainly have bladder storage symptoms, they have a strong recommendation, but they suggest that that's a weak recommendation. Don't use antimuscarinic agents in overactive bladders with post-voidal residuum volume more than 150 ml because there's a risk of going into acute urinary retention in those patients. Regarding the next agent, that's phosphodiesterase 5 inhibitors. These are the increased intracellular cyclic guanosine phosphate, GMP, that's reducing the smooth muscle tone of the detrusor, prostate, and the urethra. The licensed agent is the tadalafil 5 mg once daily regime, and there are strong recommendations with the use of phosphodiesterase type 5 inhibitors in men who have LUTs with moderate to severe symptoms, and patients who having erectile dysfunction with or without. And regarding plant extracts, there are many plant extracts suggested to be suggested to improve the LUTs, but they may be the anti-inflammatory, anti-androgenic, or estrogenic effects. But the precise mechanism of the plant extracts remains unclear. They have not widely studied in these medications. Regarding the combinations of above medications, alpha-1 blockers and 5-alpha reductase inhibitor combinations. The long-term data, around 4-year studies from the MTOPS and combat studies show that the combination treatment is superior to monotherapy for the symptoms and the Qmax, and superior to alpha-1 blocker alone in reducing the risk of acute urinary retention or need for surgery, the progression of the symptoms. And in the combat study, they have again described that the combination therapy reduces the relative risk of acute retention by 68% and the related surgery by 71%. And the symptom progression reduced by 41% compared to monotherapy with tamsulosin at 4 years. The frequency of adverse events was significantly higher for the combination therapy. That must be remembered when using combinations. And moderate to severe LUTs who are at risk of disease progression, such as patients with higher prostate volume, higher PSA concentration, and advanced age and high post-voidal residual and low Qmax patients. We can use combination therapies. Then the alpha-1 blockers and muscarinic receptor antagonist combination. Although we are using these combinations, these are not widely tested in clinical trials up to date, and they are used in moderate to severe LUTs if release of symptoms has been sufficient to monotherapy with either drug. Then the use of alpha-1 blockers and beta-3 agonists. MATCH study, they explored the effect of the addition to mirabegron 5 mg to tamsulosin 0.2 mg compared with tamsulosin plus placebo. They have showed that the total IPSS score also improved, but was not significant between the groups. So they have weak recommendation regarding use of alpha-1 blockers and beta-3 agonists. Regarding the main trials, that combination drug, MTOP study, medical therapy of prostatic symptoms. They showed that the prevention of progression of benign prostatic enlargement when compared with either drug alone. In the combat trial also, they have demonstrated that the mean prostate volume 55 ml compared to tamsulosin, dutasteride, and combination of both significantly improvements of the symptoms with combining those drugs. Thank you, sir. That's all.
Thank you, Madhushankar, for the excellent presentation.
Thank you, Madhushankar. You have done your presentation nicely with time. Satish sir, you can ask.
Yes, thank you, Madhushankar, once again. Now
you can ask questions.
Yes, I'll ask some few questions, not to intimidate you. Now, Madhushankar, you spoke about different drug classes. What are the commonly used drug classes? You are given the entire scope.
Common ones are the tamsulosin, the alpha-1 blockers, and the 5-alpha reductase inhibitors, commonly the finasteride and tamsulosin.
Yeah. Now, when it comes to tamsulosin and silodosin, now we have alpha-1, 3 subtypes. What receptors are attacked by these two drugs? 1A, 1B, alpha-1A, B, or D?
Alpha-1A expressed in the prostate, so yes.
Yeah. Tamsulosin has a weak action on alpha-1D. I mean, these are very theoretical. Now, when you prescribe tamsulosin to a 70-year-old man coming with bladder for obstruction due to prostatic enlargement, what advice would you give briefly, generally? These are few
So
personal
even though they are said to be the selective, as you mentioned, sir, there are some uh, actions on other receptors. Patient can have other orthostatic hypotension, and in elderly they can have frequent falls and things, as well as other mentioned complications they can get, sir.
Yeah, and also Silodosin has a higher rate of retroejaculation as well. You mentioned about naftopidil. I mean, just I'm asking, this is, I don't expect you to know. What type of receptors does it work on? They are alpha 1D, actually. Alpha 1D. Then you spoke about using fenestrone, I mean, 5-alpha reductive 5-ARIs in prostatic enlargement. Now, you mentioned about PSA 1.16 to 1.4, 1.4 to 1.6 would be an indication for giving finasteride. What is that? What is the importance of that PSA value?
Because with the prolonged use of finasteride, that can falsely they can show falsely low PSA values, at least around 50% reduction.
Actually, Madhushankar, now PSA value 1.5 is a watershed when it comes to this consideration of treatment. If the PSA value is more than 1.5, it shows a higher risk of rapid disease progression. Now here PSA is used not as a cancer marker, or we know it's prostate specific, to find whether this patient is going to be rapidly progressing. So here the use of PSA is another use of PSA. Use of 1.5 is a where we find whether the patient is going to have rapidly progressive disease. As you said, for more than 40 years, if there's moderate to severe symptoms, that's also indication. Now, MTOPs and combat, you rightly mentioned the value of these, but of course the adverse event rates are high with the combinations. Then regarding antimuscarinics, you very rightly said there are M2 and M3 receptors. What are the cautions when you are using a patient with mixed voiding and storage symptoms in male? What are the, will you be worried about anything?
So one thing is their side effects. Other thing is they have a high post residual volumes at around more than 150. They can go into acute retention.
Yeah, absolutely. That's one thing that you mentioned. Another thing which I liked in you, the floppy iris syndrome. Many patients have undergone problems when they're having phaco operations for cataract, where they couldn't, where the eye surgeons were unable to insert the lens. So if a patient is going for a cataract operation, always better to stop these drugs and warn the eye surgeon as well. I've seen many cases, though it's not very common. That's a very important point that you mentioned. I think I don't want to put you into trouble anymore. I think you covered the aspects very comprehensively, but we have to be mindful that this is comprehensively you have covered. One more question, Madhushankar. Now, if you are using phosphodiesterase inhibitors, like of the phosphodiesterase, do they use silodosin, avenafil, or sildenafil for this? For blood outflow obstruction.
So we are not practicing this.
Yeah, it was came to the FDA approved only about 5 years ago. The only drug that is used actually is tadalafil, and on one once-day doses. Yes. Should the patient have erectile dysfunction to use it or no?
No, sir. Both in patients who are having or not, we can use.
Absolutely. Thank you very much.
Yeah. Thank you very much.
Tivika, are you there or not?
Tivika is stuck in the theater, Muni.
Okay, sir.
Ask the next person. I have just one question, just for curiosity from Madhushankar.
Yes,
if the patient has an ejaculation, what will you do with tamsulosin or silodosin?
Sorry, sir, I don't have it.
Sorry? You don't have the answer?
Sorry,
or
sir, I
it's
have
okay?
no idea.
No. No, I'm just asking whether you
no.
can use another alpha blocker. I try to use terosacine. This is trade name is Hytrin or presocine, where I have found the side effect of anejaculation is extremely rare with those two. So you can still try
Okay.
that.
Okay, sir, thank you.
Thank you very much, Anuruddha sir.
Muni, that's the only question. Don't ask me any more. My data is finishing today, 30th of the month. No, Muni, at any moment I will get disconnected.
Actually, I'm also in a very poor situation trying to be, right?
Right. Shall we move into next presenter? That is Dr. Mahendra Herath. He will be talk about surgical management of BPH. Mahendra, over to you.
Can you see my slides? Hello? Hello?
Yes, can see, Mahendra.
Yeah, yes,
Okay.
Mahendra. Yes.
Good evening to everybody. Today my topic is surgical management of benign prostatic enlargement. This is based on EAU guideline. The indication of for surgery are the refractory urinary retention, recurrent UTI due to BPE, recurrent gross hematuria, renal insufficiency due to BPE, bladder calculi, and failed medical treatment for BPE. Then there are 5 types of surgeries. First one is resection, enucleation, vaporization, and alternative ablative techniques as well as non-ablative techniques. Then the resection methods are the monopolar and bipolar transurethral resection and thulium laser vapor resection and transurethral incision of prostate. Those are the resection techniques. Then I will come to monopolar and bipolar TURP. Here, transurethral removal of tissue from the transitional zone of gland in various degrees result in reduced volume and PSA reduction. And compared to monopolar TURP, in bipolar TURP, the energy does not travel through the body of the patient. And when we come to the efficacy of these treatment, in a meta-analysis of 20 RCT with maximum follow-up about 5 years, monopolar TURP resulted in substantial mean Qmax improvement and significant reduction of IPSS and quality of life score and post-voidal residual volume. Monopolar TURP also has durable outcome, and the failure of monopolar TURP is usually due to detrusor underactivity rather than regrowth of BPH. And usually second prosthetic operation is usually re-TURP, and it is annual is 1 to 2% annual incidence. And RCT with mild to long-term follow-up shows no difference in efficacy in parameters between monopolar and bipolar TURP as well. And when we come to tolerability and the safety, over the time, perioperative mortality and morbidity has decreased markedly, but the short-term complications include TURP syndrome, bleeding requiring transfusion, acute urinary retention, clot retention, and urinary tract infection. And long-term complications include urinary incontinence, again urinary retention, urinary tract infection, bladder neck contracture, urethral stricture, retrograde ejaculation, erectile dysfunction. Our randomized control has shown bipolar TURP is associated with improved perioperative safety, eliminating risk of TURP syndrome, reducing blood transfusion, clot retention, and hospital stay. but there is no significant difference was detected in urethral stricture rate between monopole and bipolar TURPs. And RCT also showed monopole and bipolar TURP has similar effect on erectile and ejaculatory functions. And in comparative studies evaluating safety of bipolar TURP in patients taking oral anticoagulant or antiplatelet therapy without stopping or bridging the medication, the outcome with aspirin were comparable to unmedicated control group. And under oral anticoagulation group, catheterization, hospitalization was longer, and acute rejection was higher, but blood transfusion rate did not differ to control group. In the practical consideration, monopolar TURP is effective treatment for moderate to severe LUTs due to benign prostatic enlargement, and choice should be based primarily on prostate size about 30 to 80 milliliter, and the procedure is safest when performed under the 90 minutes. Bipolar TURP in patient with moderate to severe LUTs due to BP has similar efficacy with monopolar TURP, but with lower perioperative morbidity. Choice of bipolar TURP should be based on equipment availability, surgeon's experience, and patient preference. The EUA recommendation is offer bipolar or monopolar TURP to moderate to severe LUTs in men with prostate size 30 to 80 milliliter. Then thulium vapor resection of the prostate. Here laser wavelength between 1940 and 2030 nanometer is emitted in continuous wave mode. Has similar operation, catheterization and hospitalization times compared to the TURP. Thulium vapor resection and TURP are equivalent in terms of IPSS, but not Qmax with TURP. Deemed superior 12 months of follow-up. And thulium vapor resection has similar short-term safety as TURP, but mid to long-term result on efficacy and safety compared to the TURP are very limited. So that recommendation is offer laser resection of prostate using thulium laser as an alternative to TURP. Then transurethral incision of the prostate. This involves the bladder outlet without relevant tissue removal, conventionally done with Colin knife, but there are alternative sources also available, mainly in prostate which is less than 30 milliliter without median lobe. And transurethral incision shows similar efficacy and safety to monopolar TURP for treating moderate to severe LUTs due to BP with the prostate less than 30 milliliter. No TURP surgery has been reported in the follow-up transurethral incision of prostate. There are no TURP syndrome has been reported, and risk of bleeding is negligible, and retrograde ejaculation is significantly lower, but the reoperation rate is higher compared to the monopolar TURP. The choice between TUIF and TURP should be based on primarily on the prostate volume. So the recommendation is offer transurethral incision of prostate to surgically treat moderate to severe LUTs with prostate less than 30 milliliter without median lobe. Then enucleation of the prostate. There are a few options: open prostatectomy, bipolar transurethral enucleation of the prostate, holmium laser, thulium laser, and there are a few other techniques as well. Open prostatectomy is the oldest and most invasive surgical treatment for moderate to severe LUTs due to benign prostatic enlargement. Here, obstructive adenoma is enucleated with the index finger. The approach may be either within the bladder, this is Prayer's procedure, or through the anterior prostatic capsule, that is Millin's procedure. Usually used for prostate gland which is more than 80 to 100 milliliter. So it shows similar short and mid-term efficacy to bipolar TURP and HOLEP for treating moderate to severe LUTs due to benign prostatic enlargement with the patient who is having large prostate, but has less favorable perioperative safety profile compared to the bipolar TURP and holmium laser enucleation. The long-term functional outcome of open prostatectomy are comparable to the holmium laser prostatectomy. So the recommendation is the offer open prostatectomy in the absence of bipolar TURP and holmium laser to treat moderate to severe LUTs in men with prostate more than 80 milliliter. Then bipolar transurethral enucleation of the prostate. This used the principles of bipolar technology where adenoma is enucleated endoscopically by transurethral approach. Enucleation is followed by either mosylation or resection of the removed adenoma. There are available two techniques. One is plasma kinetic technique, other one is the bipolar plasma. So they have a favorable perioperative safety profile and mid to long term efficacy compared to the TURP. This demonstrates similar mid to long term safety compared to the TURP as well. So the recommendation is offer PKEP to men with moderate to severe LUTs as an alternative to TURP. Then holmium laser enucleation of the prostate, HOLEP. The holmium laser is a pulsed solid state laser that is absorbed by water and water containing tissue. Then the tissue coagulation and necrosis occur, which is limited to 3 to 4 nanometer distance. The HOLEP has similar mid to long term efficacy and short term safety when compared to the TURP. And HOLEP has long operative time but more favorable perioperative profile when compared to the TURP. So the recommendation is offer HOLEP to men with moderate to severe LUTs as an alternative to TURP or open prostatectomy. Then thulium laser enucleation of the prostate. It again shows similar efficacy when compared with monopolar TURP, PKEP and HOLEP and bipolar TURP in short, mid and long term respectively. And thulium laser shows similar safety compared to the TURP and HOLEP in the short and mid term respectively. And thulium laser seem to be safe in patients with large prostate and those receiving anticoagulant or antiplatelet therapy as well. So the recommendation is offer thulium laser enucleation to men with moderate to severe LUTs as an alternative to TURP holmium laser. Then offer thulium to patient receiving anticoagulant or antiplatelet therapy also they have recommended. Enucleation techniques under investigation. There are a few techniques, enucleation techniques. One is minimal invasive simple prostatectomy. It is a laparoscopic or robotic assisted procedure and feasible in men with prostate who is having more than 80 milliliter, needing surgical, but they need randomized control prior to to assess further. Then the green light laser enucleation of the prostate. This again anatomical enucleation technique. Then vaporization of the prostate. There are two techniques. One is bipolar transurethral vaporization of the prostate. Other one is again green laser vaporization of the prostate. Then bipolar vaporization and TURP have similar short-term efficacy and mid-term safety, but inferior mid-term efficacy compared to TURP. And bipolar vaporization has favorable perioperative profile compared to the TURP. It again has lower short-term major morbidity compared to the TURP. So the recommendation is offer bipolar transurethral vaporization of the prostate as an alternative to TURP in patient who is having moderate to severe lust and the prostate volume 30 to 80 milliliter. There are non-ablative techniques as well. Prostatic urethral lift, intraprostatic injection. The prostatic urethral lift is a minimally invasive approach that can be done under local or general anesthesia. Here, protruding lateral lobes are compressed by small permanent suture-based implants delivered under cystoscopy guidance, and it results in opening of the prostatic urethra, leaving a continuous anterior channel to the prostatic fossa. The long-term side effects have not been evaluated still. And prostatic urethral lift improve IPSS score, Qmax and quality of life, but these improvements are inferior to TURP at 24 months. People has a low incidence of sexual side effects. So the recommendation is offer posterior prostatic urethral lift to men with LUTs interested in preserving ejaculatory function and the prostate is less than 70 milliliter with no middle lobe. Then intraprostatic injection. there are various substances have been tried. The example are the botulinum toxin, NX1207, and etc. But the no clinical benefits have been observed with the botulinum. Trial has shown clinical benefits with NX1207 compared to the placebo. Then there are alternative ablative techniques. One is aquablation, other one is prosthetic artery embolization. But prosthetic artery embolization is less effective than TURP at improving symptoms and urodynamic parameters. So this is the overall summary of my presentation. Thank you very much.
Thank you, Mahendra. Satish sir, you can ask.
I can do this also there, I think. Hi,
Yes.
Mahendra, thanks a lot for your excellent presentation. I think you covered the entire gamut of procedures available for prostate surgery. Now, Mahendra, what are the common procedures you see? I mean, research level ones also. What are the common surgical options we offer in our country generally?
We offer TURP and TURIS as well as open prostatectomy, sir.
Yeah, and also the TUIP, which we call as a bladder neck incision.
Yes.
Now,
Yes.
you mentioned if you are doing a TU, I mean, if you have recourse to other endoscopic procedures, before doing a TUIP, would you like to do any other procedure? Considering the criteria you mentioned.
So I will do the rigid cystoscopy and assess whether there is a median lobe or not.
Absolutely. I think best thing is to do a flexible cystoscopy.
Yes.
And then assess the median lobe. Now, we had these problems, I think all of us have faced this. So sometimes doubtful situations, you would have to do a flexible cystoscopy and check whether it's amenable to TUIP. I think, as you said, it is quite a simple procedure with low morbidity. Now, open prostatectomy, you mentioned that if the prostate is more than 100 ml, you will consider. Any other indications for open prostatectomy, which is a dying operation, but it's been done occasionally. One thing is a large prostate. Otherwise, any other indications you can think of?
If you don't have facilities,
if the patient is
yes, nowadays we have more than 40 urologists around. Yes, it was done. Yeah, other thing is, Mahendra, is one thing is a large. Other thing is, if we are not in a position to put the patient in a lithotomy position, sometimes they can have various hip joint problems. That also could be come with the bladder stone, or the patient has large diverticula. Then, of course, also you can consider open. But once again, large diverticulum would imply the patient is having underactive detrusor also. So we have to be a bit careful. So those are the other indications. Can't put on lithotomy and significant bladder pathologies. Now, what are the indicators? Now, if a patient, you are states, we have to say all patients of CRO, chronic retention will have to go for retention. Will have to go. Now, are there any predictors of unsatisfactory performance after TURP? When will you consider? Sometimes TURP might not work. In general population, 80% would work.
Yeah, I think I can remember the question was asked by you in the exam also to me, sir. Yeah, the residual volume is more, then we have to suspect dextrose inactivity. So in that case, following surgery also, patient might have more chance to get retention. And the Qmax is also more in the pre-operative assessment, then that is also that means the 75%. Normally, the QMX is less than 90% of the chance to have successful TURP following surgery. Patient will be able to avoid. If it is
Actually,
more than
sorry, go on.
if it is more than
Absolutely. Then when it comes to this patients, the best test would be to, in a Western setup, we have facilities to do a urodynamic study, cystometry, and find whether the patient has a low pressure, low flow system or a high pressure, low flow system. A high pressure, low flow system will do very well after surgery, but a low pressure, low flow system will not perform that well after surgery. So that is a predictive factor which in our country we have to guess. But in a typical situation, that patient will be have to be subjected to urodynamics. From that emanates the EAU indications for urodynamics before prostate surgery. Mahendra, I mean, are you aware of the before prostate surgery?
So if we suspect any bladder underactivity or activity, or if we can't absolutely sure this is due to a purely benign prostatic enlargement, we need to do.
Yeah, the criteria says if the patient has a residual of more than 300 ml, if the patient is below 50 years or 80 years, and if the patient can't pass more than 150 ml of urine at a time, or if the patient has had a previous surgery, prostatic surgery. Those are the flow criteria that the AU gives for assessment. But this is fine-tuning, but later on, this is important. Thank you. Anirudh.
Mahendra, your indication, you said BPE with renal impairment, but I think better to modify it as high pressure chronic retention, because renal impairment may be due to parenchymal disease, and it is, I don't think we should consider it as an indication. Someone might think like that. So better to modify it as high pressure chronic retention.
Yeah, I know that.
That's all.
To say that it's obstructive neuropathy, it's correct to that, isn't it? Then other point is, I mean, this is not in the classical indications. If the patient can't afford to buy medication, now that has become a problem now. Patient can't afford to buy. Then also you'll have to consider this type of TURP. And also if the patient is having occupation, which is young, relatively young, the patient can't find drugs, he's on a catheter, then exams, but then it's very important to consider them for a fast track TURP.
waiting with the TURP techniques and TURP syndrome. Over to you, Chaminda.
Good evening. So today my topic is to discuss about TRP syndrome and the TRP techniques. So hope you can see my slides there.
Yes, Chaminda, you can go ahead.
So when when we moving into this TRP syndrome, so first of all, whether to go ahead with either TUR syndrome or TRP syndrome is a problem. So because this is not only seen with the TURP, it also seen in other procedures including TURBT, PCNL, as well as even for the diagnostic cystoscopy. And apart from that, this also can seen in other surgeries such as orthopedic surgeries including the arthroscopy and gynecological surgeries. So when it comes to the introduction, so this is and the modality, again, less than 0.8% with the mild to moderate disease, but it might go up as high as 25% with the severe disease. So this might manifest early as 15 minutes intraoperatively, even up to the 24 hours post-operative period. When going to this pathophysiology of TURP syndrome, so usually we use this irrigation fluid to increase our vision and as well as about this thermal damage. Ideal irrigation fluid, it should be isotonic, non-hemolytic, and as well as electrically inert, and also non-toxic and transparent and easy to sterilize. So traditionally, we use this 1.5% glycine initially, but now it has gone away from the trend, and apart from that, other hypertonic solution including sorbitol or mannitol, and currently we use the sterile water, and with the TURIs, we use physiological saline. When it goes into the pathophysiology, we use this pressurized water with this fluid with about the patient's body level. And during this resection, there will be this opening up of prostatic sinus where this pressurized water or this hypertonic fluid will directly inoculated into the system, and there will be a rapid and large quantity absorption. So the ultimate result would be this rapid large quantity absorption result in the fluid overload, and the hypertonic fluid absorption will result in dilutional hyponatremia, and the glycine absorption causes its own glycine toxicity. When it comes to the fluid overload, with each and every TURP, there is small amount of fluid absorption will occur, but when it comes to 1 liter absorption is more than 1 liter per hour, there will be an appearance of those symptoms will be there. So rapid shock due to fluid shift from this pulmonary edema or a metabolic acidosis. And
Excuse me, can I interrupt for a while? Is there a hypertension with tachycardia or bradycardia?
So here there is a reflex tachycardia, they might develop with hypertension.
It should be bradycardia.
Okay, then I will look at it. And if the patient having this coexisting poor left ventricular function, they might develop pulmonary edema as well. And with this hypotonic absorption of the hypotonic fluid will result in dilutional hyponatremia. When the serum sodium, if it is dropped less than 120, that will cause this severe form of TURP syndrome. So the decreasement of this serum sodium will result in brain edema and as well as raised intracranial pressure and neurological symptoms. Or in the severe and rapidly evolving hyponatremia will manifest with the seizure, coma, and even brainstem herniation and death. When considering about this glycine toxicity, it has its own direct toxicity to the myocardium, which will cause this T inversion seen on the ECG and as well as myocardial ischemia. And also glycine acts as inhibitor neurotransmitter in the retina, will causing the visual disturbance. And it also causes hypoxaluria and causing the acute kidney injury. And as well as it will metabolize into the ammonia, which is causing the hyperammonemia and causing this glycine-induced encephalopathy. When it comes to the clinical manifestations, those are again related to this pathophysiological mechanism. So usually in the perioperative period, the earliest symptoms would be the prickling and burning sensation of the face and neck, and as well as coexisting lethargy, restlessness, and the headache. And post-operatively, patient might develop nausea, visual disturbance, and focal or generalized seizures. So management include this. It's better to identify those patients early. So the monitoring of high-risk patient is theoretically discussable point, but the practical use is still questionable. So the estimation of amount of irrigation fluid absorption during this endoscopic procedure, there are several ways introduced, including this ethanol monitoring method, where this ethanol mix irrigation fluid use and the ethanol concentration in the exhaled air is measured, and as well as central venous pressure monitoring and gravimetry, where the patient body weight measurement. And the mild symptomatic patients, so those can manage with the supportive therapy, including the antiemetics with the high dependency unit with the monitoring. And this bradycardia and the hypotension can be managed with the these adrenergic drugs, and as well as plasma volume expansion if necessary. And the management of severe hyponatremia is somewhat challenging, because this rapid correction of this hyponatremia with the hypertonic saline, which might cause this fetal central pontine melanosis. So the correction should be take with the combined with the intensive support. So the correction should not exceed 1 millimole per liter per hour. And the management of seizure, again, it's due to this TRP and capillopathy. So those include this NMDA receptor antagonist or glycine agonist or glycine antagonist. Or there are some places for magnesium therapy as well. Pulmonary edema can be managed with the furosemide. So when it comes to the visual disturbance, usually this half-life of glycine is around 85 minutes. So usually with the fading away of this glycine will improve the vision. So we don't have to do anything actively. So the prevention, when it comes to the prevention of TURPs, so what we have to do is we have to reverse the pathophysiology. So in that case, we can think about the reduction of the absorption as well as the changing of the fluid, and and as well as reduce other way of inserting this intravenous fluids. So when considering the reduction of the absorption, we can think about this preparative position of the patient. The reverse tender of the position will reduce the intravesical pressure, and as well as the operative time should be minimum. So if we can confine to the 1 hour, it would be great. And as well as the fluid bag height, so recommendation is about 60 centimeter, but it should be corrected according to our vision. So it should be kept at the ideal height with the proper vision, but not too high. And we can use the low pressure irrigation, and as well as there are some indication for intraprostatic vasopressin injection. And instead of glycine, nowadays we use this sterile water or other hypertonic saline, so that will remove this glycine toxicity. And with the evaluation of the theories, so we can use the physiological saline. So this dilutional hyponatremia are no longer there. Instead of that, there will be hypochloremic metabolic acidosis. And apart from the surgeons, the anesthetists also had a role. So we have to ask them to minimize the to infuse the intravenous fluid, and as well as intermittent use of diuretics. And when moving into the TURP techniques, so the indications initially discussed by the Mahendra, and when going into the contraindication, so there are this: if there's ongoing acute urinary tract infection or uncontrolled coagulopathy, it's better to postpone the surgery. And when considering the anesthesia, general or spinal anesthesia we can prefer, but spinal anesthesia preferred in the view of this identification of TUR syndrome. So equipments we all know, but this for this evacuation of the prostatic particles, we can use elective equator or Tourniquet syringe according to the availability. The positioning should be a dorsal lithotomy position with adequate padding and security, and buttock should be placed at the edge of the table. Otherwise, this anterior section would be difficult. So, if necessary, if some surgeons would practice this elevation of the prostate with the index finger transrectal route, in that case, use of O'Connor type rectal sheet also indicated. The first step would be doing this erythrocystoscopy, where we look for this bladder, for any bladder pathology, and as well as bladder neck and tricone and position of the ureteric orifices and verumentanum and external. So if there's any difficulty in identification of ureteric orifices, so we can use this IV indicocarmine for the visualization of ureteric orifices, but the use is doubt. When it comes to this basic technical things, so in the cutting techniques, the first, when we are cutting on at the initial part, it's advisable to take this wide and deep as the loop as long as it travels. So it's like a canoe-like chips. And when it comes to the hemostasis, it's better to know about the anatomy of this vascular anatomy of the prostate. There are usually those branches from the internal iliac arteries, which will enter at the vesicoprostatic junction, usually at this 11 and 1 o'clock position. Those are called flux arteries, and as well as there are some arteries from this 5 and 7, but majority of those arteries condense at the level of this 3 to 5 and 9 to 7 positions. And hemostatic techniques, so we can, while we are cutting, we can use the loop. If it is small one, we can control by coagulation its mouth, and if it is a large vessel, we can control by pushing it, applying the pressure on the lateral side. Before going to the surgery, so we should have this, and we should identify the anatomical landmarks. So this includes this verumentanum, which will indicate the external sphincter, and as well as we have predetermined endpoints. So usually at the level of this proximal level of the verumentanum, as well as the predetermined starting point. And we can fix our sheet at the level of verumentanum with the use of other non-dominant hand. And if really necessary, we can go for retrograde cutting, but it is it's not advisable to do, as risk of perforation is high. So there are a lot of methods of TURP, including Barnes' next bit, and the proper technique would be the best practice and best understood by this particular urologist. So little bit about those techniques. The Barnes method, where it start the resection at the median lobe and then follow the lateral lobes from the bottom to top. So that's usually for the beginners. So we also practice that. And next bits, where we start at the 12 o'clock position, and as well as some says it's start from 11 and 1 o'clock position, and lateral lobes will be resected from top to bottom, and median lobe will be the last. And other ones include this Alcock and Flox method, Momias method, and the Blandis. So those are different kind of methods. And at the end, so we have to evacuate the strips. So this Milo Helix invented this Helix, which we'll use to evacuate this thing. If it is not available, we can go for this 2 syringe. And after surgery, this catheter placement is an important thing. So either we can use this via guided catheterization or a free catheterization with the 3-way catheter. And the balloon, the amount of volume of the balloon should be determined with the size of the prostatic fossa. So it should be filled to avoid it will comes back to the prostatic fossa. And if necessary, we can apply we can hold it with the plaster into the thigh to make this tamponade defect. So complication initially discussed by the Mahendra. And when it comes to this monopolar and bipolar techniques, so the bipolar the current doesn't traverse through the body. So the importance is that we can use the physiological saline, and but technique is almost similar, but also it allows quicker resection due to simultaneous cutting and sealing of the blood vessels. And as Mahendra mentioned, there's comparative study found similar efficacy between those two in the form of this improvement of IPSS, Qmax, or reduction of residual volume. and overall rate of adverse event is, but overall adverse events are lower with the bipolar TURP. Though Mahendra mentioned that there is no increased risk of urethral strictures with the bipolar, but with this TURIS, I think it's not a proper bipolar TURP where it's this passive electrode that will be the sheath of the equipment. So there will be a high rate of urethral stricture with the TURIS. So that will conclude my presentation, and thank you.
Thank you, Jaminder. You have done very nice presentation, and with the deep explanation about the techniques. And just before going to experts, just mention me what is the technique we usually do.
Yes, so what we usually go with this initial resection of the median lobe, and then do the lateral resection from below to from down to upward. So it's looks more towards this Barnes methods, but I'm not very sure.
Okay. Satish sir.
Yes, thanks a lot for that excellent presentation. Now, just one thing I'm curious. Now, you mentioned Chandan, about this TUR syndrome, and while you're operating, you become aware the anesthetist comes to know. I mean, identify that the patient has a TUR syndrome, moderate. Like, so you're the urologist. What are you going to do when you're told, oh, this patient has a TUR syndrome? Evidence is there. What are you going to get excited, or what are you going to do?
Yes, sir. In that case, I'm thinking of this bailout procedure. So I will ask my anesthetist to stabilize the patient and avoid this any further IV fluids, and give some amount of furosemide. And if patient developing mild to moderate symptoms, so then in that case I want to stop my procedure immediately. So I will go, if I'm going with the one lobe resection, so I will stop the procedure at that level, and I will achieve my hemostasis, and I will ask them to recover the patient.
Absolutely. I mean, very, very correct. You have to stop the procedure, come out as fast as possible, you achieve hemostasis. And catheter placement, anything special? Are you going to use traction or not going to use it? I mean, it's variable, but generally, what would you like to do?
And generally, in our practice, we apply the traction.
Yeah. What about the irrigation? Are you going to use a lot of irrigation or absolutely minimal type of irrigation?
Yes, sir. It should be absolutely minimal irrigation. So if only necessary, we have to start the irrigation, and only if there's ongoing hemorrhage is there, we have to continue the irrigation more than 24 hours. Otherwise, it's a minimal irrigation.
Yeah. And any intraoperative things that you'd observe that, I mean, it doesn't happen in all the cases, that patient will potentially develop TUR syndrome. We don't see it very commonly. What are the things or small intraoperative observations that would be an indicator? Not always.
One thing is patient would be restless as patient on spinal anesthesia, and as some says that there will be abdominal distensions due to this
extravasation. Yeah. No, the thing is endoscopically, what would you observe? Sometimes, I mean, it's not always. If the patient has capsular perforation, evidence of capsular perforation, and increased venous oozing, I mean, those are just rough indicators, but they're not absolute though. I think your presentation on TURP was excellent. Actually, I hardly have any questions to ask actually on those. But once again, you have touched on all the techniques very well with the pros and cons. One thing about bipolar, the thing is patients on pacemakers, they have advantage. We can do a better safe operation than with monopolar. So bipolar, that's another indication. As you very rightly said, there could be urethral injuries if the sheath is going down as passive conductor. Anirudh, any questions? Anirudh, you are there? If the patient is having intractable hematuria, patient is outside in the recovery area, and the recovery nurses say there's thick red blood coming out. These were all of us experience. What will you do, Chavinder?
So in that case, the probability is that we have missed some arterial bleeding. So in that case, if still patient is on the recovery, I won't hesitate to take him into the theater and do the cystoscopy, and if there's any bleeding, to coagulate, sir.
Yeah, we will first we will try sort of putting more irrigation, ice cool ones, and yeah. I mean, that's the best thing actually. Go take it into theater rather than procrastinating to go in and have a look at a bladder, do a proper bladder shut and coagulation. Otherwise, there'll be a lot of problems. But some will try clot evacuations, then using higher irrigation rates. Any other questions? Thanks, Chaminda.
Chaminda, you have planned a patient for TURP. Once you go inside, there is a large stones also. So how you manage this, handle this?
If there's a large stone, so that is a relative contraindication for a TURB at the same time. So in that case, I will first go ahead with this. If it is possible, I will go ahead with this cystoscopic lithotripsy, and later I will plan for a surgery. But if it is really indicated to do both surgeries at the same time, so first I will go for a cystoscopic lithotripsy. After completing that, I would prefer to do the TURP to avoid minimize the bleeding post-operative.
Yeah, you have to do the first stone surgery and complete with the time and everything depend on that. You have to go ahead with the TURP. And
basic idea is to reduce the TURP syndrome. After doing the TURP, if you go and do stone surgery, then you are putting the infected urine and the stone particle into the venous system.
Absolutely.
That might be the reason.
Chamindra, one little question. The patient who has had a super TURP with excellent flow rates, he comes with, he says he had excellent flow initially, and he comes after about 1 year. Say that, doctor, I have a slow urination. How would you assess this patient? What are your thoughts at that very particular moment?
Yeah, that may be due to this remaining apical tissue or this bladder neck area, which might cause this membranous type occlusion. So in that case, I will assess him with the flexible cystoscopy. If there is anything, then I will go for any rigid cystoscopy and dilatation.
Yes, but of course, there are two things to think about mainly at urethral strictures. There could be stricture formation with instrumentation and bladder sclerosis or stenosis, we call it. Then if it is, as you say, you have to do a flexible cystoscopy. If you find a bladder sclerosis, what are you going to do? What approach are you going to take?
So in that case, one thing I can go ahead with this bladder neck incision, but
yeah. Actually, yes. Actually, you do a bladder neck incision, backward cutting or forward cutting. The sectoscope, what you'll use? It should be forward cutting. You'll have to use the forward cutting resectoscope because you can't come backwards. So you use the resectoscope with the forward cutting, what we use for internal urethrotomy. That particular working element can be used actually. So that's another technical point just to ask. One more point I think for all trainees, this is an important point. Munipre, may I ask this question?
Yeah, yes, sir, yes.
Yeah. Now, if the urine flow rate, now we want the flow rates. For the urine flow rates to go down, what is the minimum, what is the urethral caliber that which flow rates will start to go down?
It's less than 9 French.
Yeah, absolutely. You are really correct. It should be 10 or 9 French, less than that. This was described by a great urologist called Joe Smith in Oxford. He did studies putting needles into their bladders themselves, and they did studies, and they did various models, and they won the Bowes Prize for this, 1967. Joe Smith showed that if the urethral caliber should be less than 9 or 10 French for the urine flow rates to go. That is the premise on which even strictures, if their caliber is less than, if it's more than 9 or 10, they'll have normal flow rates. So that's a bit of a catch situation. Thank you.
I think Tivika is still stuck at theater. So every training is you have to read about the pathophysiology of the BPH and the early assessment of the lower urine tract symptoms, because we are planning the first lecture is the pathophysiology and the LUTS symptoms. So everybody knows about that. We have to fine tune all the details of those things, especially when it comes to the exit exam. And then, so shall we conclude the today Uromet?
Yeah, one little thing to tell as well.
Yeah.
When it comes to these terminologies, as Munipriya very rightly said, what is LUTS, what is bladder outflow obstruction, what is BPH, what is BPE, and how they fit into that Venn diagram of Tech Hall, which all of us know. Those conceptual things have to be very well understood. And as Munipriya very rightly said, we'll have to understand the pathophysiology of the lower tract really well. The receptors are not like to sort of, you are not going to be a chemical scientist, but at least what happens, where these receptors are, how it works. And also the IPSS to have idea. It comes in clinical assessment, these scoring systems. Are we going to do it in routine situations? But it's more used in research and when we are comparing or following up patients with a given treatment. So IPSS, if you are going for the exit exam, you'll have to know about the symptom scores, and at least as an instrument, and they are validated by Professor Neville Pereira into Sinhala as well. So we have validated questionnaires translated in Sinhala in Sri Lanka. That work was done by Neville sir, and those are available actually. Tamil, I'm not very sure. And those are important. And when it comes to TURP, I would strongly recommend, there are some myths in this book. If you can get hold of if you can get hold of a copy, that will be a nice book to read. TUR, transurethral dissection. That's like a Bible. Some of you would have read it. I mean, that's an important book. I think you have to read every day. Thank you, Munipriya, and thanks for inviting me. And thanks, Anuruddha, if you are there. I wonder whether your data is there, as you said. And I'm very happy with the presentation. Thank you very much.
Thank you very much, sir. Before the conclusion, we would thanks the SLOUS Academic Committee as well as the our organizers, the sponsors, CIPLA. So today Uromet, we will meet in next week, probably again Friday, with next Uromet. Okay, thank you very much for joining everybody and do the night presentation. Thank you very much, Satish sir. Your valuable time spent for our trainees. Thank you, sir.
Thank you.
Good night.
Good night. Good night.